talk. Next, I call upon Dr. Anju for her talk on upper lid blepharoplasty.
Good morning, all. Thank you, Soumya, for the opportunity, and it is very heartening to see a full house today. After hearing all the experts talk, mine is a beginner's perspective. So, anybody in the audience, can you identify who this is? Anybody? Okay, so how did Norma Jean Baker go from this to this? And what is the relevance in today's presentation? So, if you look at her eyes, she has definitely undergone an upper lid blepharoplasty. So, as early as in the 19th century, blepharoplasty has been reported, and the very term blepharon refers to eyelids, and plasticos means to mold. So, as you saw already earlier, it is a surgical procedure where the eyelid skin, the orbicularis oculi muscle, and the orbital fat is either excised, redraped, or sculpted for aesthetic or even for functional abnormalities. So, we'll just briefly look at the anatomy again of the upper eyelid this time. So, eyelid skin is the thinnest in the body, and it is unique for not having subcutaneous fat. And the levator palpebrae superioris, which is the main elevator or the retractor of the eyelid, it has several insertions, and one of the insertions is the reason for the upper lid crease. And it has two fat pads, and we have two fat pads, one in the medial and the middle, and the lateral is occupied by a lacrimal gland. So with aging, what happens is the skin becomes thinner. You notice dermatochalasis. There's associated fat prolapse, and also patients do come with brotosis, which is important in the management later because blepharoplasty alone would not be sufficient for the patient, and an associated blepharotosis as well. So you saw in detail how to choose a good candidate. The main indications once again would be dermatochalasis, blepharochalasis in thyroid eye disease once the active phase has subsided, and in patients who have had trauma and for cosmetic purposes. It's very, very important to have a detailed history, once again emphasizing on taking a history of bleeding diathesis and use of anticoagulants. And one thing which most patients would like to hide from their doctors is any history of previous surgeries, which you should always rule out. Corneal status and tear production need to be recorded in all cases. And a thorough preoperative counseling, you talk the patient through the surgical procedure so that they have a realistic outcome. Photo documentation is very important, both prior to the surgery and post-surgery as well. You always take a front photo, an oblique view, and a profile photo, which is a side photo. You should spend immense amount of time in just the preoperative marking, as was described by Dr. Akshay earlier. This is the skin pinch technique, whereby you pinch the excess amount of skin to make sure that you do not excise too much of the skin or the orbicularis, resulting in lag of thalamus later. And you should remember to keep always a minimum of 20 millimeters of the upper lid in order to maintain the anterior lamella. So I'll briefly run you through the surgical technique. So once the marking has been done, then you excise the upper lid skin, followed by excising a small part of the orbicularis around 4 to 5 millimeters. And depending upon the orbital fat prolapse, you excise part of the orbital fat after coagulation. And remember to take lid crease forming sutures from the orbicularis to the LPS. And closure can be done either by interrupted or continuous sutures. This is preferably done under local anesthesia, where a mixture of lignocaine plus adrenaline is given for good hemostasis. So one thing that you would ask the patient to avoid is to restart their anticoagulants and blood thinners at least for a week. And I'll finish in a minute. And ask them to avoid lifting heavy weights. And as part of the healing, some people tend to develop pigmentation, so avoid excessive sunlight exposure and copious lubricants because there can be altered tear film disturbances. Complications: hematoma, asymmetry, lag of thalamus, ptosis, dry eye syndrome, orbital hematoma or compartment syndrome, which needs to be addressed quickly, lymphedema, and ocular motility disorders. This usually happens when there is excessive dissection. So this was one of my patients who had come with a history of previous 2 excisions already, but she was still unhappy. If you look at her, she kept complaining about the upper lid swelling that she had. And on palpation, that was actually the prolapsed lacrimal gland. So what she underwent was a bilateral lacrimal gland repositioning with blepharoplasty, minimum blepharoplasty under local anesthesia. And this is her at post-op, and she's much happier. So in interest of time, I guess we will have to skip the surgical video. Thank you all for patient hearing.
Thank you, Dr. Anju. And we are open to questions from the audience. If anyone has any questions for any of our speakers till now. If there are no questions, we can move